So I am presenting this work on behalf of an enormous amount of work done by lots of other people, obviously including myself, but I've had the very great privilege of working across three major institutions, which is the Rockefeller University in New York, who invented these antibodies, Michelle Nussensweig's group, and myself and the group at Imperial College in London in the UK, and then Oxford University. And this has been a collaboration that's been going on for, as often happens with these trials, for many, many years. And we are very grateful to be able to present this to you. And the work is essentially funded by the Bill and Melinda Gates Foundation through the Cure initiative led by Mike McCune, who many of you are very aware of. So the first instance is to say this is an enormous undertaking, and particularly for our study participants. They come extremely frequently. They stop their medicines. They take blood samples literally every week. And we are eternally grateful for the study teams, participants, family, partners, and partners, of course, have to take PrEP to prevent the risk of transmission. And the people in the picture you can see are the study leadership who have put this all together. So I hardly need to tell anyone on this call that antiretroviral therapy is amazing, but I think it's always valuable to pause on that moment before we start thinking about remission and cure and realize how extraordinary the impact of treatment is, both for people growing up with HIV, people aging with HIV, and of course the reduction in the risk of onward transmission. But even with injectable agents available to us, they require lifelong delivery of treatment. And that, of course, is a significant challenge, particularly in the world right now. And I hardly need to point out to the group here on this call that this is an enormous burden and a risk for children growing up with HIV in resource-limited settings where they were far more dependent on delivery of treatment and testing by US funds that have subsequently been closed down. So with that in mind, if people go to a clinic and they find that the clinic is closed or their treatment is not available, what actually happens when people stop taking their medicines? And we know from many studies now that virus rebounds really very quickly, within about 14 to 21 days for most people, even those who started therapy around the time of early infection or around the time of virus transmission for children. We actually recently published a meta-analysis of trials amongst adults who had stopped therapy just to look at how common this actually is. And you can see here, each individual squiggly line represents the viral rebound of people who've been in these studies. This is data from 385 individual study participants. And we show here, this is people who have had no additional intervention, no BNABs, nothing. And you can see here that the dark line shows that the average time to viral rebound above the different thresholds on the y-axis is, again, within a few weeks for 96% of the individuals. And for those people who started early, and by early we mean within 6 months from the diagnosis of acute infection, still rebound is in the vast majority, but it's slightly more common. About 6% of the individuals in this study maintained viral rebound below 1,000 copies up to 84 days after stopping. Those people who started treatment a bit later, so after 6 months, it's really quite vanishingly rare. So we know that when treatment is interrupted, certainly amongst adults, this is a common observation. So the question that many of us want to know is how can we do better than this, given that the challenges of maintaining lifelong access to treatment are certainly challenging right now. And so I just thought I'd explore the science, and I'm sure you're all very familiar with this, but why can't the antiretroviral therapy that we have at the moment cure HIV? And of course, it is because of the existence of these pools of infected cells with HIV DNA incorporated into them, the so-called resting or reservoir cells, which become activated as soon as we release antiretroviral therapy. And even though these cells are vanishingly rare, we think amongst adults on treatment, they're probably less than 1 in a million CD4 cells. Sorry, these cells have the capacity to produce virus replication from clonal expansion as soon as antiretroviral therapy is stopped. So we move on to what kind of treatments are good. And I just was sort of reviewing, where does this idea of passive antibody treatment come from for infectious diseases? And there have been studies on using passive immunization using antibodies for over 100 years. And you can see here that this was used in 1901, where a Nobel Prize was given to Emil von Behring, who looked at diphtheria. Fleming obviously identified penicillin, not an antibody, and that's really why the field kind of slightly paused, because for infectious diseases, suddenly antibiotics became a much more feasible option than using passive immunization to treat infectious diseases. But once Milstein had worked out how to clone B cells to make monoclonal antibodies, then the field has really moved on. And it's really in the last 10 years that the enhanced ability to produce monoclonal antibodies with higher potency and longer half-lives has really helped us in our field in HIV. So what is a broadly neutralizing antibody? We call a broadly neutralizing antibody, and this is an in vitro definition, that these antibodies can recognize and block entry of a broad range of different strains of HIV into healthy cells. The antigen binding site binds to the envelope glycoprotein of HIV, and the Fc portion of the antibody has other immune-based functions. And that's one of the key things that we think is very helpful for the HIV broadly neutralizing field, because it is able to enhance immune functions of other cells of the immune system and potentially confer lasting immunity when the antibody levels have actually declined. So where do these broadly neutralizing antibodies come from? Individuals living with HIV make antibodies. About 25% of those people living with HIV have broadly neutralizing antibodies that have subsequently been cloned. And these antibodies that we are using in Rio actually originated from people living with HIV attending the Rockefeller. This is a picture that many of you are, again, very familiar with. And the two blocks that I've outlined here in red are the two antibodies that we have used and are probably the most developed, in that there's the most clinical information on 101074 and 3BNC117. And they bind to the V3 loop of the HIV envelope glycoprotein and the CD4 binding site, respectively. But the beauty of this slide shows you that there are multiple other antibodies in development at various different stages, some of them subsequently bought by drug companies, and some of them ongoing in research trials at the moment. At the moment, they're sort of unmemorable names and numbers, but it just shows us that there is an enormous interest in the field, and it's very reassuring that these are being developed as we go. And this slide was made in 2012, so you can see that this is just the beginning of the research in our field. So just to review again how we think these BNAbs might be working, how might they do better than antiretroviral therapy? Well, as I've mentioned, they were particularly selected because they block virus infection of uninfected cells, but they may also engage, and we will hear from Paolo, the importance of the NK cells and the innate effector cells that may also be facilitated and switched on following the introduction of broadly neutralizing antibodies here, as you can see. And in addition, they may induce HIV-specific memory T cells, both CD4 and CD8, the so-called vaccinal effect. And the figure below here shows an example of a SHIV model where animals were given antibodies, and then on the bottom right-hand side figure were given anti-CD8 monoclonals. And you can see here that when the anti-CD8 monoclonals deleted the animal's CD8 responses, virus came back, and as they washed out, virus was subsequently suppressed once again. So there is evidence from animal models and some initial human studies that have identified a similar vaccinal kind of effect. And then more recently, the Fc domains of these antibodies have been enhanced with a mutation that has allowed enhanced modification that has allowed enhanced half-lives of these antibodies. And this has really enhanced the field, because it means now that one IV infusion, or one, ideally an injection, can recycle over the Fc receptor on many of the cells, which allows them to stay at therapeutic levels for the next 6 to 9 months after dosing. The next point when we're designing these studies is how do we pick the right BNAB? So these antibodies have got to bind to that individual person's viruses to enable most of these effects that I've just talked about to actually function. And we have seen that in the early BNAB studies in humans and in adults, the people who got the best response were those people who had viral reservoirs or viral sequences that responded to the antibodies they were given. And it sounds an easy test to do. We're very familiar with looking at viral sequences to test whether antiretroviral therapies work. So we've kind of thought we should be able to tell it with the BNABs, but it's not quite developed to the level that we would like at the moment. So some people are using a phenotype kind of assay, which for the older ones amongst us may remember we tried to do this when we had the CCR5 inhibiting drugs. This is a convoluted process. They take the host, the individual participant's virus, we put it through a cell pseudovirus system, and then the output is, do the viruses grow out of the system when you add the BNABs, and you get a quantified report. That's quite time consuming, it's expensive, and it's imperfect. The other option is to actually have a look at the envelope sequences where we think we have identified mutations which mean these antibodies don't bind. And this is an example here of what we've been using in Rio, where the red mutations we think confer resistance to 1074 and the yellow ones to 3BNC. But again, some of the data, as you'll see, they're imperfect. So neither assay is ideal, but we do know that we need to work much harder to develop these better. And I assume AI models will help us with this. And also the more data we get from studies, the better. So just to summarize before I go into the data of the trial, the rise of these HIV-specific broadly neutralizing antibodies are powerful antiviral agents, but they raise a number of research questions. Are they effective as antiviral agents, and could they play a role in switching into standard anti-HIV therapies? And does this long-acting impact of that LS variant I showed to you, it's got huge potential, and particularly for the group of you on this meeting, they have the potential to prevent vertical transmission with one injection. And also for those individuals who are struggling with adherence, having one injection that has capacity to last at least once or twice a year would be a game changer. There has been very little data in a randomized trial of these LS variant antibodies to date. And so the trial I'm going to talk to you about is one of the first to demonstrate their efficacy. And what we are also looking at is there a post-BNAB effect that could induce remission or even cure? And what's the mechanism of this? Is this mediated by a vaccinal type effect? And that's what we're looking at the moment. So these are the slides in the Rio trial that I presented at CROI. And again, it's a work of enormous numbers of people, both in the laboratory, in the clinics, and of course for our participants and the management of the such trial. So overall, Rio is a double-blind, randomized control trial, one-to-one allocation, and it was designed in 2 stages. So initially, people living with HIV reservoirs. So from DNA, we identified, we thought they did not have resistance to the BNABs we're using. And then they were identified to stop therapy and receive either a blinded dose of the 2 BNABs or placebo. And then they stopped treatment and had weekly viral load measurements with our initial primary endpoint up to week 20, looking at the percentage of participants who remained undetectable off therapy by week 20 by study arm. For people who were in the placebo arm, you can see here what is called stage 2, where once their virus rebounded, they were unblinded, they restarted antiretroviral therapy, and they were given BNABs at the time of viral rebound. The data I'm going to show you today is not including that of stage 2 because that is still ongoing. So the question that we were asking in stage 1 of the study is, can 2 BNABs confer significant viral suppression off antiretroviral therapy, and how does that compare with placebo? And if we do see this, how is the mechanism happening, and for how long does it last? So what we're doing here as a cartoon diagram is we find individuals who were diagnosed in early or acute HIV infection. They started antiretroviral therapy, and then when they are eligible for the study, they stop their antiretroviral therapy, so that grey line stops, and then they receive BNAB, if you like, into the ATI. And what we anticipate seeing is that those who had resistant virus or the bNAbs don't work will rebound quite quickly. And those people who had sensitive viruses, the bNAbs would confer months or potentially years of viral suppression. And obviously we compared this to people who had placebo. So this is just to summarize what we're looking at from now on. So we have 34 people in each arm blindly allocated to receive bNAb or placebo, and the primary study endpoint was at week 20 after they stopped therapy. We then added a sub-study, which was still blinded, that people after week 20 could receive a second dose. And if those people were in placebo, they received a second dose of blinded placebo. So the eligibility for individuals who enrolled in this study were those people who'd started treatment in acute or early infection. They had a good CD4 count. They'd been suppressed on therapy for at least a year, and they had no significant co-infections or comorbidities, and all their partners had free access to PrEP and appropriate protection. The viral rebound primary endpoint is defined here, and this is in line with the published recommendation that was in the Lancet a couple of years ago, showing that we would identify the first date of viral rebound of a greater than 1,000 copies for 6 consecutive weeks, or greater than 100,000 copies for 2 weeks, for 2 readings 1 week apart, or any instances slightly outside of these that were reviewed by an independent panel. And of course, participants could choose to restart therapy, or if there was any clinical indication to restart therapy, that was also of note. And these are demographics of the individuals we have enrolled, as reflects the population of people who were eligible and interested in the UK. They are all cisgender men, aged around about 39 years. They had very good or normal CD4 counts at enrollment. The majority were a B-clade virus, and the majority started their HIV therapy around the time of acute infection. And here is the result of the primary endpoint, which, if you remember, was the viral rebound by week 20. And you can see here in blue is the bNAb arm, and in red is the placebo. So this is a Kaplan-Meier plot where the y-axis is the percentage of participants who have rebounded, where at the beginning nobody had rebounded. So that starts at the top. And then along the x-axis is the time from antiretroviral pause. And you can see out to week 20, there is a significant difference between the 2 study arms, with a hazard ratio of 0.09 and a significant p-value here. So by week 20, we found 75% of the people who'd received bNAbs had not rebounded, compared to 8% of those who'd had placebo. And some people restarted therapy prior to viral rebound, so their data is censored, which is the lines. So we then wanted to know what happened after week 20, and this is the similar Kaplan-Meier plot, same color scheme. bNAbs is blue and placebo is red. And this is now out to week 72 after after stopping therapy. And again, the hazard ratio now is 0.24 by study arm, again, still statistically significant. And here by week 48, so almost a year after stopping therapy, over half the people who had received bNAbs had still not yet rebounded, whereas 2 people in the control arm, placebo arm, had not rebounded. By week 72, this has dropped to 40%, but still quite extraordinary that for 2 doses of IV infusions, 40% of the participants had not rebounded. So actually what we saw in overall view of just those people in arm A now was 3 patterns of viral rebound. So there were some people in the top panel who we called group 1. They rebounded before 20 weeks. There were 8 out of the 34 people that this applied to. 4 of those, when we sequenced virus at rebound, had resistant viruses to the antibodies. And they all rebounded at quite high levels of antibody in the plasma. So for whatever reason, we incorrectly selected, if you like, participants that we thought were eligible. The second panel are really interesting mechanistically. So this is a group of people who had a delayed rebound between week 20 and week 96. So still a very long time after they had stopped their therapy. Here we saw rebound around about 20 micrograms per mil of the antibodies. And these participants have, as you can see, a sort of oscillatory pattern of virus coming back. And then the bottom group is those individuals who have not rebounded at all, and this is up to beyond week 96. And there's 5 people so far who have remained off therapy and who have not rebounded in this group. This is the PK of the BNABs, work done by Ming Li, who's just completed his PhD with us, and it fits exactly with, as anticipated, the initial data that was presented by the Rockefeller team, and the work is done by the group at Duke University, headed by Kelly Seaton and Georgia Tamaris. And you can see here that 1 dose of antibody, and the doses you can see were given here on a 10 milligrams per kilogram or 30 milligrams per kilogram, really last at very high therapeutic levels for at least 6 months and probably longer. In terms of the safety, we saw 8 serious adverse events and 1 death, none related to BNAB or the ATI, no infusion reactions, no declines in CD4 count, and no HIV transmissions. We did see people rebound quite high. So of the 76 people who have interrupted therapy, 5 people had viral rebounds over 1 million. And you can see here those individual participant plots, how long they were off therapy before their virus reached these sort of heights, and then how long it took them to resuppress after they'd started treatment again. So for the vast majority of people after starting therapy, and the reason I'm laboring this point is it's really important for us clinicians to know how effective the therapy, the antiretrovirals are when they restart, and they're very effective. Most of our participants really wanted to know this, and the majority of people resuppressed certainly by 12 weeks, most of them before that, but 3 individual people took a bit longer. And there was no difference in time to viral resuppression by study arm here. So you can see again, placebo in red and BNAB in blue. And then finally, there's some very initial data from John Frater's group in Oxford to show us, was there a vaccinal effect? How is this happening? And these are people in arm A, so who received BNABs but had not any detectable virus, because obviously if you're measuring HIV-specific immunity, if there's any viremia, that in itself may well induce new responses. And you can see in these 3 panels in terms of the ELISpot, CD8 proliferation, and CD4 aim, that individuals at different time points along the bottom, time 0, week 12, 20 to 24 or 36 after stopping treatment, remaining undetectable, we have evidence of new HIV-specific CD8 and CD4 T cell responses. And this work was also presented at CROI in a poster, as noted here. So what do I think we've seen? We think that the BNABs clearly have a direct antiviral effect. And for those people in that middle group, probably as BNAB levels decline, some of those people begun to rebound. But for those people who maintain viral control well after 72 weeks, we're beginning to suggest that there is a longer lasting polyfunctional CD8, CD4, potentially innate immune response. And this is all work that's ongoing, so I don't have any data to present on that. So what are we going to do next? We're doing lots of biomarker work. We're looking at the impact on the reservoir. This work is being done by our American colleagues at the Rockefeller and Harvard. And we are doing a lot more work on the arm B of this study, which is it better to give BNABs when people are viremic? So these parts of the study are now open to analysis, arm B, and arm C is another part of the study where we're having 2 periods of viremia with the thought to prime the immune response, then control viremia, and then allow a second rebound when antibody is given. And that study is enrolling at the moment. And I think in the interest of time, I will stop there. And thank you very much for your patience and for listening.
It's a real honor to speak after Sarah Fidler about this wonderful data. I think actually I want to thank her also for setting the stage of knowledge about what we also call viral remission. And I should apologize for these my initial slides, because actually I think this need to be updated after Sarah data. But actually, so far we have 2 ways to achieve viral remission that we know clearly. And these were actually through bone marrow transplantation. There are a number of data that have been published in the literature over the recent year. Some of the colleagues actually that are connected, actually, they really contribute also to these findings. And another aspect that actually is, of course, is of interest for us is through early treatment. We know that actually through early treatment, a number of patients, very few actually, but a number of them have been described. Maybe actually a number of these are also actually present in the court that actually Alfredo has been followed together with the Hepical group in multiple settings in Africa. And the idea is that beside actually the early treatment, actually in adult courts, what so far is the higher percentage actually of patients actually experiencing viral remission. In adult courts, actually, this data is, let's say, a little bit more clear, even if it's relatively low. In pediatric patients, actually, these percentages still need to be a little bit investigated due to the fact that we are still missing clear, actually, treatment interruption studies in large courts. And so far, a number of, let's say, case reports have been described. And I just want to highlight actually the recent finding published by Philip Coulter in his Nature Medicine paper, where actually he could actually identify 6 patients under viral remission. So according to these, let's say, different findings, we can argue, hypothesize that actually the frequency of the rate actually of viral remission in pediatric cohorts is around 5%, but we cannot really say too much due to the fact that we were not able so far to design actually treatment interruption studies, particularly based on let's say immunological and virological criteria. So far, what we understood about this let's say this aspect of HIV remission, that this is still a complex interplay between reservoir and immunity, and we know that some factors are strictly related to the virus itself, and we know that actually some of these factors can be identified in the lower viral reservoir, but nowadays we know that this definition is going to be more detailed in a more granular way, and also actually we can actually argue that the immunity or immune system of the host can play a role. So for those of you that are interested in this phenomena, I would suggest to read actually the recent special issue that has been published in Current Opinion of Age. I think it was actually the special issue was directly edited by Professor Savita Power in Miami, and actually it reports a number actually of different information, a number of different data regarding actually the phenomena of HIV remission in pediatric settings, and how actually this can be defined, and which are the players that can play a role here. What is really clear actually in the recent year, that new technology enable nowadays a multidimensional analysis of HIV reservoir. And actually many of these technologies that are reported here, they do allow us to quantify the provirus, and they do allow us to really to understand actually where the provirus is integrated at chromosome level. And actually, many of these technology have been optimized in Matthias Lichtenfeld lab. So actually, the work is a really collaborative work that I want to present to you today. What we have done instead so far, we tried to optimize actually a multi-parameter approach, I would say multi-layer approach in our lab actually. And this is something that was done in collaboration with many colleagues actually in my lab. I just want to thank Professor Nicola Cotugno, who recently actually became associate professor at the University of Tor Vergata, but many other colleagues who play a role here and try to understand actually not only the frequency of the cells when we evaluate the immune response upon infection or upon vaccination, so not only to evaluate the frequency, but also try to look at the transcriptome level, so what's changed in terms of gene expression, in terms of RNA sequencing within the cells upon actually a certain stimulation. We look at a methylation profile of the cells, and as well as which cytokines are produced upon certain stimulation. And the question that we try to answer is if there unique immunological features of the pediatric immune system which can interact and possibly target HIV reservoir cells during long-term art. And as I mentioned before, was really a collaborative work where all the virology studies that I'm going to present were kindly provided by Matthias Lab at MIT, and I would say actually Benjamin Bone, that is nowadays working in Savida's lab, actually is played a crucial role. And as I mentioned before, actually the guys here were very important in the data analysis and in the evaluation and in the production of many of the analyses. So really, actually, these patients that I'm going to present you today, they really undergo to an extensive immunological experimental plan, which will involve many people of the lab, which means that we look at the T cells profiles in this patient, but more recently also the B cells and monocytes. We look at an NK cell compartment as well as at the plasma antibodies and let's say also at the cytokine production in this patient. And the results of this excessive and massive work was this paper that has been I think it's just out actually in this week. And the first information that I think actually I want to share with you that this was feasible thanks to a huge collaboration, excellent collaboration that we had with clinicians that actually are taking care of this patient together with us. So I want to thank Stefania Bernardi, who actually has been following these patients with me since the very beginning, and Nicole Colantoni, actually, who is a resident in pediatrics, who is currently working in Matthias Lichter's lab, who was really instrumental for setting actually the logistic of this study, and later on in running some of the experiment. And the first information is that leukapheresis is a safe procedure that can be applied also in pediatric age, which allow us to collect a quite large amount of cells. As you can see here, the billion of cells that were collected from each of the study participants. These data were already presented at CROI, but I just want to highlight the fact that this study that, let's say, started and was initially granted through a HAPICAL consortium and was possible to continue thanks to the pay fundings, really allow us to collect a large amount of cells, which means also the possibility to run our deep viral reservoir evaluation in a large amount of cells. So in these slides here are reported the demographic of the so-called leukoid cohort, which is the name that we identify for this cohort. This is a cohort that has been followed since the very beginning in Rome, and that this cohort has been actually identified thanks to the fact that we have been, I would say, working since the very beginning in the concept of early treatment in Rome, trying to really to promote the idea that an early treatment actually is more efficient in preserving immune cell recovery and also in preserve actually the so-called actually better immune functionality of the immune system in our patients. Among our cohort in Rome, we identified 9 individuals. I just want to highlight some of the features of these guys here. I think in terms of sex, you can see that actually we don't actually serve a real gender issue, so it's quite balanced in terms of the cohort, in terms of males and females. All of them, they start treatment within the first year of life, but with some difference in terms of months, as you can see here. What if we think actually can play a real role in some of the data that I'm going to present you later on is the fact that some of them, they experience a co-infection in terms of CMV at birth, but also the fact actually that in terms of time to virological suppression, as you can see here, some patients, and I just want to show you overall the so-called patient leuco-9, who takes actually much longer than the other patient to fully suppress viral load in the long terms. In terms actually of long-term virological history, you can see that actually the results are reported here. There are not, I would say, no particular interest, despite the fact that the leuconine, again, actually experienced one episode of real viral rebound, according to also the same criteria that was previously mentioned by Sarah of one detection of viral load over 1,000 copy. And for the study purpose, actually, we also had the opportunity, and this also thanks to Matthias and actually his previous data, to compare these patients, so these patients of perinatally infected groups, with a group of adult patients that have been, I would say, longitudinally follow-up at Boston Center, and one group that was defined as a moderate ART cohort of patients with undetectable viral load over time, with a median duration of undetectable viremia of 8 years, and another group, actually more interesting, of elite controllers patients, which means that these are patients actually that were able to maintain virological suppression over time for a long time. So the first information that actually comes from this comparison exercise actually is the fact that participants in the leukoid cohort exhibit a much, I would say, a significant lower frequency of intact provirus overall. This is something that is clear if you compare actually the group, actually in terms of, I would say, overall proviruses. And what is interesting actually to know that whereas actually I can imagine that this finding was expected in comparison to the so-called what we call moderate ART here of adults that have been late treated under long-term treatment and virological suppression. The findings that is reported here in comparison to elite controllers was somehow unexpected. So this level of patient in comparison to the adult core patients, they really display a distant virological features, which means that overall they have actually a total HIV provirus which is absolutely lower in comparison to the other groups. And these are in this table here are reported actually the number of PBNC that have been analyzed from each actually individuals. Just to mention the fact that this finding is coming really from a very large amount of cells that were isolated and investigated and analyzed. So if we go actually a little bit into the details of the cohort and we look at the phylogenetic and chromosomal position of HIV intact provirus according to this cohort, it is interesting to first of all to show that actually viral evolution through early treatment is somehow actually controlled. And this is something that was also showing from previous findings, actually from Debbie Pursuit lab. What I think actually was interesting in this cohort that actually in some particular individuals, actually such as LECO9, LECO5, LECO and LECO1, and as well as LECO5, actually very few actually provirus, in some cases no single intact provirus were identified, were detected actually, despite the analysis that was performed in billions of PBNC. In some patients actually, when I say we, actually I mean Matthias and Benjamin, they also perform viral outgrowth assay, but they were not able to isolate any provirus and any replicating virus in these patients. So what we try to understand is how is the immune system of these, let's say, of these individuals, and particularly of these 3 individuals where actually basically provirus is almost absent. And what we try to do, we firstly analyze actually T cell compartment, and we try to evaluate actually specific T cell responses in this group. This was done through 2 different approaches, one standard ELISpot assay, but also we perform actually lymphoproliferation assay. This actually last approach was run in Bruce Walker's lab. And this was done actually with epitopes HLA binding approach that actually um, were restricted for gag. And as you can see here, this is something that is quite interesting to show for both the approach. The patient so-called leuconine, that is the patient that actually presented, let's say, a lower time to virological suppression, interestingly present an important lymphoproliferation response and a restricted gag response, actually, in comparison to the rest of the group. Um, Another information that is quite important for us, since actually, according to Sarah, we we also understood the importance of evaluating antibody response in this patient, and we initially performed this analysis in Rome through what we call Western blot analysis. Basically, this is a very simple test where you can detect actually seroresponse to 10 different antigens, and you can actually come out with a score, which is, in our opinion, informative of the virological history of the patient, but also actually of the time to virological suppression in certain individuals. As you can see here, some of the participants in the of course, they remain seronegative over time. Some of them actually they change their score in terms of negativity, so some positivity turn out in negative response, whereas some of the patients actually increase their sero response. What I think it is important to notice here that, and this is a phenomena that is reported, and this is also fueling one question that I have for Sarah later on, that early treatment is a unique actually opportunity for us to really act on the viral reservoir, but at the same time also we think is going to impact the ability of an individual to mount HIV-specific immune response over time. And this is quite clear if you look at the correlation that comes from the T cell response here and the HIV-specific antibodies over time. You see that there is a strict correlation between actually follicular specific, CD4 follicular T cells and the presence or the absence of um, of antibodies over time. So those patients that actually have been treated very, very early within the first, let's say, days or weeks of life, they can be seronegative and they can maintain this seronegative over time, which also means that actually they do also miss a T cell specific, HIV specific T cell response over time. This is something that we need to take in consideration when we select actually the criteria for treatment interruption in our patient. But then actually, we thought to look also at the NK compartment. This is a huge work that has been run in the lab by Chiara Pigli, who is postdoc actually in the lab, and Arianna Rotili, who is a PhD candidate. And basically, they set up, let's say, a multi-panel approach. That is something that was feasible through and was run through the so-called BD Symphony instrument. So we were able to optimize up to 30 parameters to look at the sales compartment, but we tried to keep actually initially a very simple approach based also to the possibility that we have, we wanted to compare this data with the adult cohorts that were and the adult data that were provided by Matthias. As you can see here, we try to look at very simply at those so-called those cells that are, let's say, the NK cells that are more activated, but and these cells actually that instead that they have a preserved cytotoxicity and they are considered better NK. So if you look actually the comparative results here, you can see that the population that is defined as the 56 bright population, so those cells that are actually um, let's simplify in a way that we can say they are better in K in comparison to the adult patients. Actually, you see that there is a huge difference, whereas actually this is the same. Actually, when we look actually at the opposite side. And this findings is quite important and is in line of what we previously actually described through the apical collaboration in the karma court, where we were also able to show that actually patients that were treated only, sorry? Okay. So patients that were treated only, actually, they have a preserved NK cell compartment. What I think is important to mention here that if we look at the Lakoff court, actually, there is an effect likely correlated with the timing of artemisation that actually allow, I would say, an enrichment of this particular NK cell subset, which is a CD56 bright and 57 positive within the NK population. And this actually subpopulation is quite of interest of us. I just want to mention that in the context of cancer treatment, the presence and expansion of these cells has been linked more recently with survival, for instance, versus melanoma. And actually, there is a strict correlation between the presence of these cells and the level of the effective copies per million PBNC in this court.
Nada, ni un minuto y ya has hecho amigo.
Okay, I don't know if
Excuse me. If you can mute your phone, please.
Okay, sorry. So the point that I want to make here, that this particular subset is also of interest for us, actually, that in this patient we see an enrichment of NK cell subsets that are so-called adaptive NK cells, that are those that actually mostly mediate ADCC. And that actually was quite normal for us try to look actually at ADCC in these patients. And again, actually, it's quite interesting to observe that ADCC in these 9 patients is strictly related to some viral reservoir features. And for this reason, actually, we do believe that this is quite informative, and we would like to adapt actually this approach in the upcoming ENABLE trial that actually is going to be designed and led by Alfredo in different South African settings. So I just want to conclude here because actually we are around of time, and maybe actually there are questions that we would like to answer. And I also would like to raise a question to Sarah. Just saying that young adults with perinatal acquired HIV, as you can see here, they do have a much smaller viral reservoir in comparison to the other group of patients. This means that these actually smaller reservoir, as I mentioned before, present actually, I would say, a different rate of evolution, which means that actually basically in theory actually these patients actually are more eligible for a personalized approach, which does not mean at all actually that these patients they will remain actually under virological remission once treatment is interrupted if we just look at these particular features. But I just want to say that new technology nowadays allow us to really to go into the details of the viral reservoir in our patients, and in this case, in some participants actually, we really detect 0 or very few actually provirus in out of millions of PBNC. And this, of course, is one of the features that we would like to look at if we want to design actually maybe treatment interruption strategy, and we want to select actually some eligible criteria for future treatment interruption studies. Our patients, actually, patients that are perinatally HIV infected that will be treated early, they do preserve an higher frequency of CD56 bright NK cells in comparison to the adult groups. And we do believe that these particular subsets can play a role in shaping the viral reservoir. Of course, this is not possible to run definitive conclusions, but our aim and our idea is really to follow up with this study with with a treatment interruption study in some of the participants of this Leukov cohort. This has been described quite a lot in the last years, and I think we just recently find to an agreement with one of the patients. And one aspect that I want to discuss with you, and was also touched by Sarah, is the fact that when you design treatment interruption study, there is a major effort for our patients actually, because actually usually the treatment schedules are really heavy, and patients need to really to come back almost every week in order to run virological evaluations. So this is something that we need to keep in mind. And it's also in terms of patient selection. Many of the patients here are, let's say, young adults. They do have their life, and of course, actually, we need to really to match our studies with their needs. This is something that is quite clear. And I thank, and I will really to again thank all the participants in this study, because for them it's a really a huge effort in terms of time actually. And we do believe, again, this is my final conclusion, the reservoir size is inversely associated with this particular subset, that is 57 bright and positive and 56 bright in K cells, and also actually DCC function can play a major role. And I would be interested to understand in Sarah actually data if they look at these parameters actually in the Rio in the Rio study. I want to stop here. I really want to thank again all the people that really collaborated actually in this work. Again, Matthias for all the virological data that he provided from the study cohort, Benjamin Von, actually my PhD Liber Assessa, who initiate this work actually in Matthias lab, and also actually, of course, Nicola Cotugno, who play again a critical role here, and all the people in the lab, in particular also Dr. Paola Leone, who was really instrumental, is responsible for our leukopharisy unit, so was really helpful in setting up actually the experimental design here.
I give the floor to Mark and Adi to start running the questions and answers. Mark and Adi.
Okay, I'm going to start. Firstly, thanks. I think they were two great talks. One, a BNAB strategy trial, which is incredibly exciting and implementable. And then Paolo's really in-depth, comprehensive study of long-term the Leuko trial, who have really well characterized young adults on very long-term treatment, with some hints at what is going to be needed in the next step. I have two very quick questions, and one's for Sarah and one's for Paolo, and both reflect my ignorance. And for Sarah, just to briefly ask why only were males in the Rio trial. And I'm going to ask Paolo's question as well. If you could just explain simply what CD57 plus 56 bright means in terms of function. That's clearly having an amazing effect on the reservoir. So I'll just start with question one for Sarah and then question two for Paolo.
Mark, thank you. And thanks for all the nice comments. I really appreciate it. I wish I hadn't got to tell you that they were all men. Basically, I think it reflects the cohort that we look after in the UK. So we wanted to start this as a kind of mechanistic strategic study. And so we wanted to enroll people who had basically a good immune system. So we decided to enroll people only if they started antiretrovirals with a CD4 nadir of greater than 500, or they had evidence of acute infection. And because of the nature of the population we look after here, most of the young gay men had frequently tested for HIV, and so they were diagnosed in acute infection and gone straight onto treatment. So I actually think it's a reflection of the cohorts we were looking after rather than anything else. We would have loved to enroll women. And just to add a really important study that was done by colleagues in South Africa. So Tumbi and Dungu's group, and they presented at CROI as well, for those people who were there, presented what they call the FRESH trial, which is using slightly different antibodies amongst young women who were similarly diagnosed around the time of acute infection, started on treatment and did a very similar sort of strategy to our stage 1, where it was a single arm study in his group, but he had 20 young women who were basically switched from antiretroviral therapy to 2B NABs with lefitolimod. And that study showed similarly really extended viral control off therapy. So that's a long answer to your question. I wish we could enroll women, but Tumbi has done it, and the group in South Africa, and hopefully we will be able to duplicate findings in different genders and in different settings.
Thanks. Paolo, if you could just explain to me and probably many other people on the webinar a little bit about the NK function, which is just absolutely fascinating, so we can understand a little bit more.
Okay, thank you, Mark. Actually, first of all, I must say that we are all ignorant, actually, when we talk about actually this aspect, because we are learning by our patients. So all the questions are very welcome. Thank you for your question, which is actually is a very important question, and also a very difficult actually question, because the real point here is that first of all, I would like to say that we still do not really understand in immunology when actually cells is activated or when a cell actually is improperly, I would say, activated, which means an age, cells that actually contribute to age, contribute to inflammation. So this particular subset is of interest for us. And what I want to say that actually this comes out from an intensive bioinformatic analysis where actually all the parameters actually were analyzed altogether. And this was one of the key parameters which actually came out to our attention. So this is not something that I would say, we initially look at directly, because the real point here is that usually this subset actually is reported in many studies, at least in the past was reported 57 as a marker of aging cells, which means that these cells actually are, I would say, cells that actually produce quite a lot of cytokines in theory, but actually they're not really specific. But what I think it is mostly interesting that there are recent findings that have been published by the groups, for instance, from Anna Herbst. There is a nice paper in Journal Immunology which show actually that NK cells can play a role, quite important role, in, let's say, linking what we call adaptive words, so on the antibody words, with the functionality of the cells. So antibodies that are actually maybe non-neutralizing. Actually, we still don't know. Actually, some of the neutralizing antibodies, they also have quite important DCC activity, but some actually antibodies that cannot be neutralized can also mediate ADCC, which means can mediate cytotoxicity, so can lead the cells in the place actually where actually that are infected to the cells that are infected and control actually the virus. So what I want to say here that this particular subset was investigated by other colleagues actually, and mostly the information are coming from the colleagues in the cancer. And it seems that these cells actually, they are infiltrating the tissue actually, and they are able somehow to control the expansion actually of the metastasis actually in the cancer world. What does this mean actually in terms of HIV? I mean, this is just a really hypothesis. I mean, unfortunately, as you know, one of the major limitations that we do have in our pediatric HIV cure world is that we do not have really access to the tissue. So this is something that actually we need to keep in mind, but it is possible that can play a role actually in maintaining actually the cells, maintaining let's say the or in leading actually in maintaining the provirus actually at tissue level. This is something that it is just an hypothesis. It's not actually, unfortunately, it is not possible to demonstrate at the moment. We in the Ithaco study we have been working actually, and we are trying to take some gut biopsy in some of the patients, but still actually, as reported here, the likely of identifying infected cells at tissue level is very low. And the real
Sorry,
point.
Paolo, we're gonna leave a little bit time for Adi to do some questions and to leave some floor for other to ask.
When they ask me,
Thank you, Paolo.
All right. Thank you, Pab. Thank you, Paolo, and thank you, Sarah, for those great presentations. So my first question goes to Sarah. Given what you have presented, what do you think would be the best time to give BNAPs and why? And do you think the existing BNAPs would also work for all clades? Because most of it now is all clade B. Would it also work for us here in Uganda, A and D? And what do you think is the role of AI in all this? You know, because I think we need to think about it, and you who has been in it would be able to. Now, to Paolo, again, my question goes to the NK cell subsets, the CD4, 56, and CD4 and CD57. It's very interesting indeed. And I wanted to know from at this point where you are, do you see any feasibility of us who are interested in ATI to use these and be able to say, yes, these are the children we can characterize, or young adults we can characterize and do ATI. And, you know, then we move on from there. Thank you.
Sarah, please first.
I'm just trying to frantically remember all the questions. So your first question is a really good one, and I wish I knew the answer. So in the trial that we've called Rio, so we will know if the effects of giving a BNAB when somebody is virally suppressed is really what we've just seen now. So that's kind of, if you like, a switch study. They do seem to work very effectively, and it kind of, the context of that is Gilead have done really quite a decent phase 2 study. When I say decent, as in a decent number of people have been enrolled who had the same 2 BNABs that we have used in Rio with lenacapavir, and showed it was extraordinarily effective. So perhaps, and I don't know the mechanistic effects of that study, but perhaps the addition of lenacapavir would sort of mop up those people, if you like, the wrong word, but you know, the context that we haven't chosen the right BNABs for every single person. So in our study, I'm thinking of those people who rebounded quite early on with potentially resistant virus. So if you gave the BNABs with lenacapavir, that could be quite a good strategy to potentially cover people who we're not quite good enough as yet at identifying the right BNABs. There is data that originally came, again, this is all work in adults as far as I'm aware, of giving BNABs when people are viremic. And originally that came from the group in Denmark with the eClear trial, where they gave people BNABs at the time that ART was started, so at ART initiation. And they showed, again, a persistent effect when people stop therapy even a year later. So the mechanistic idea there is that they have induced an HIV-specific response, so the vaccinal effect that has lasted. So there became a sort of paradigm in the world of BNABs where people thought, well, it might be better to give them when there's viremia. because what you're doing is basically, instead of having a latency reversing drug, you've got reservoir cells that are expressing antigen, and that might help clear them. And I feel like we will find some data from arm B. So the bit we're waiting for now is those people who had placebo, they rebounded, they then received BNAbs when they were viremic. And I don't know the answer to that yet, but we will have that data set probably next year when people have completed that part of the trial. And there are other studies ongoing, particularly there's an ACTG study in women, predominantly in Africa, where they are giving BNAbs at viremia. I think that's ongoing in South Africa and in Zimbabwe. Many of your colleagues may well be more familiar with it than I am. So that sort of looks at, should we be giving BNAbs at viremia? So the obvious way to do that is either at ART initiation, or it is to do an approach like we have done, where you let people be viremic, they go back on treatment and you give BNAbs then, and then you have to ask them to do a second or potentially third treatment interruption with the context or concept that you are, if you like, letting virus activated reservoir cells wake up, avoids needing a latency reversing drug. So that's a very long answer to your question, and the short answer is I don't actually know. The second question you asked me was, were these the right BNAbs for all different clades of HIV? And again, they are called broadly neutralizing, but what I think I've said to you before is that these antibodies, we don't have the perfect test, and that's where I think AI, to answer your other question, could really help us. I am definitely not a virology expert, and many of you on the call probably are, but you can probably see that the more data we get about what is a therapeutic level of antibody that we want to maintain, when do we call remission? So is that when antibody levels go beyond the level that we can detect in plasma? If they're still undetectable, there must be some other mechanism maintaining viral control, or the antibodies have flushed out most of the active reservoir and it's kind of, we've turned them into a sort of spontaneous elite controller kind of phenotype. I think that although these antibodies are broad in vitro, I think you can see even in the cohorts we're looking at that in vivo they are imperfect. And there has been studies by the Harvard group looking at 3 different antibodies, again in children, and showing that 3 antibodies might be better than 2 because you're getting an enhanced breadth. Probably we want to have not only antibodies, but they've all got to bind at different parts of the envelope glycoprotein to avoid developing resistance. And I think I don't yet know. So a lot of words to say, I don't know the answer to that one either. Which is the perfect antibody cocktail? I don't know. As I'm sure you're aware in your study that you alluded to earlier, amongst the children that predominantly don't have B clade virus, how we find the best antibodies for them, maybe to use antibody technologies to sort of generate antibodies that are right for their virus. And there are some really interesting very early phase 1 vaccine designs that are trying to generate production of the right broadly neutralizing antibodies, because that in a perfect world would mean you don't need to have this passive infusion process, which again, although it replaces the need for lifelong therapy, at the moment we think we might need to keep giving people dosing. I hope I've answered most of your questions, but probably not with a clear answer.
Thank you, Sarah.
Okay, and it's my turn. I try to be very short, actually, because we are out of time. I must say that if I want to couple actually with Sarah answer, first of all, I think actually that involvement of early treated patient is quite important. But what I think actually is important also, so certain time of early treatment is a parameter that I would take in consideration. But as Sarah pointed out, actually, it's very important also the deep study of our patient before actually we run a treatment interruption study. So coming back to your question, I think that this population of NK cells with higher cytotoxicity in comparison to let's say also others NK cell subset is one of the parameters that we need to take in consideration. But also I think the seronegative status is something that we need to keep in mind, as well as the presence or the absence of a specific T cell response. Actually, in other words, my impression is that it's critically important to consider if those patients have actually an HIV-specific response in place, and then try to understand which type of HIV-specific response is in place, and finally, actually, we can try to come to identification of those patients that can be eligible for treatment interruption studies.